Agradecemos también a quienes desde el día de ayer y el día de hoy nos han seguido a través de redes sociales y plataformas digitales. Los invitamos a compartir las ligas y el contenido de nuestras redes sociales, @mitosalcohol. En continuación a los trabajos del primer Congreso Internacional en México de Trastornos del Espectro Alcohólico Fetal, quiero recordarles que el día de hoy tenemos la presencia de ponentes internacionales y nacionales y estará centrado en la etapa postnatal, cuando ya existió exposición prenatal al alcohol y nos enfrentamos a los retos de diagnóstico y abordaje. Es por eso que nuestros invitados vienen de países en donde el tema está muy avanzado y vienen a compartirnos su experiencia. A todos ellos, muchas gracias. Sin más preámbulo, vamos a comenzar. Quisiera presentar en la ponencia número 1 a Fisiopatología de los Trastornos del Espectro Alcohólico Fetal y desarrollo del Código de 4 dígitos, presentada por la doctora Susan Astley Hemingway. La doctora Astley Hemingway se especializa principalmente en los trastornos del espectro alcohólico fetal. Es directora de la Red de Diagnóstico y Prevención del Trastorno en el estado de Washington. La FASDPN es una red de clínicas comunitarias del estado de Washington, conectadas por el Centro Clínico de Investigación y Capacitación del Centro de Desarrollo Humano y Discapacidad de la Universidad de Washington. La misión de la FASDPN es la prevención primaria y secundaria del trastorno mediante la detección, el diagnóstico, la intervención, la capacitación, la educación y la investigación. La doctora Hemingway ha desarrollado un sistema integral para el diagnóstico del trastorno, el Código Diagnóstico de 4 dígitos del trastorno del espectro alcohólico fetal. El curso en línea del Código de 4 dígitos, el software de análisis fotográfico facial del trastorno para el diagnóstico y la detección de los rasgos faciales del trastorno y el programa de detección del trastorno del espectro alcohólico fetal en hogares de acogida en el condado de King. Ha capacitado a más de 150 equipos de diagnóstico del trastorno en todo el mundo, como se muestra en los paneles de tabló del FASDPN. Doctora, sea usted bienvenida. Gracias.
Thank you very much. It's an absolute honor to be here. I thank you very much for the invitation. I'm going to share with you a number of topics related to fetal alcohol spectrum disorder diagnosis. It will be at a very introductory level. Their time doesn't permit to go into the details, but I want to assure you every topic I cover today, there are one or more published papers on our website, free access, that if you'd like more detail, by all means, please do that. And before I end too, while I have your attention, I'd like to invite each and every one of you, not all on the same day, to join us in clinic. We hold clinic on Fridays in Seattle, Washington, and we have up to 10 community professionals worldwide Zoom in and watch the whole process. You're welcome at any time to do that. Just simply contact me. The topics that I'm going to share with you today are the following. By now, after yesterday's talks, you should know the answer to what is FASD, but I'll briefly go over that. How to diagnose FASD using the 4-digit code. What is the prevalence and pattern of neurodevelopmental impairment? And then my colleague, Dr. Aaron Olson, is going to share that in much more detail following me. Is there a safe level of alcohol consumption during pregnancy? What is the prevalence and impact of other prenatal and postnatal risk factors in this population? What does the face of FAS look like and how to measure it using the photo software? If time permits, I'll show you a brief video of me actually measuring an individual's facial features, how the FAS face can actually serve as a very effective screening tool for FAS, our FASD prevention efforts working. The goal of everybody in this room is to put us out of business, okay, is to prevent FASD to the extent possible. And then I'll want to share with you, we do provide free training and diagnostic tools worldwide and how to access those. So again, fetal alcohol spectrum disorders is characterized by pre or postnatal growth deficiency, a unique cluster of 3 facial minor anomalies. I'll share some photos with you to show you what those are. And then perhaps most importantly, the structural, neurological, or functional brain abnormalities. FASD is caused by prenatal alcohol exposure, and it does exist on a continuum, a very important continuum, from mild to severe. I'll often refer to the syndrome, fetal alcohol syndrome, but that's just the tip of the iceberg, okay? The individuals that perhaps need the most help in intervention services are those that don't have the obvious facial features. At the University of Washington, we conduct FASD evaluations using an interdisciplinary team and the 4-digit code. And our team, here's a picture of some of the past members. Our team includes a pediatrician, a psychologist, a speech-language pathologist, an occupational therapist, a social worker, and a family advocate. You don't need that many people on a team if that's hard for you to get started, but it is a kind of a Cadillac model of what you would hope to put together. And we use these tools that we've created over the decades to diagnose them, and I'll show you how we use them. Again, there won't be time in this presentation to share with you the fact that the 4-digit code is fully validated. The evidence base that supports that is published both on our website in an audio augmented PDF if you'd like to watch that. And it's also, all of our publications are summarized in a single validation paper. All of these things are available to you on our website. So the 4-digit code. Here's a graphic way to kind of present it. Again, I shared with you that FASD is typified by growth deficiency, facial features, evidence of brain damage, and alcohol exposure. And we take each one of these and we code them on a 4-point scale, with 1 being normal, 2 mild, 3 moderate, and 4 severe. And so, for example, with growth deficiency, we consider normal growth anybody who presents with height and weight above the 10th centile. We consider severe growth deficiency are individuals who have height and weight below the 3rd percentile, kind of off the growth charts. When we look at the facial features, you can see each one of these is kind of on a continuum. A rank 1 is you have none of the facial features. A rank 2 is you have 1 or 2 of them. A rank 3 is you have 2.5 of them. And a rank 4 is you have all 3 of them. In other words, every aspect of FASD exists on a continuum, a very clinically important continuum, okay? The brain scale, the 4-point brain scale, is actually 2 scales in 1. The first question we address in clinic is, does the individual with prenatal alcohol exposure presenting with any structural or neurological evidence of damage? Structurally, we'll measure their head circumference, brain size. Is it small, microcephalic? Or maybe they've had an MRI that's abnormal. That would get you to a rank 4. Or if they have a seizure disorder, that would get you to a rank 4. But we're not done. Let's say the individual has microcephaly, but we haven't said anything about their brain function. What about their function? And so the ranks 1, 2, and 3 are actually addressing, but where is their functional status? Do they have normal function, moderate dysfunction, or severe dysfunction? So we're actually addressing those in kind of a 2-step process. So in this particular hypothetical case that I've shown, you can see I've circled height at the rank 3, face at a rank 4, severe dysfunction at a rank 3, and confirmed high exposure gets a rank 4. So now we've just generated a 4-digit code, 3434. But what's that? And so the way you know what that is if you see the chart on the right, we have taken all the different 4-digit code combinations that qualify for what we would call FAS, and that's how you know as a clinician, this is a code that meets the criteria for FAS. There's another series of codes that qualify for the next diagnosis under the umbrella, static encephalopathy. So it's very straightforward. As much as people say it's so complicated to diagnose FASD, it's actually very straightforward to do it. So under the umbrella of FASD, in accordance with the 4-digit code, are 3 meaningful diagnostic classifications. The most severe is FAS, and as you can see, the green boxes, these are the individuals that present with growth deficiency, the facial features, severe brain damage, and the alcohol exposure. The next one under the umbrella is static encephalopathy, alcohol exposed. Static encephalopathy is just a generic medical term for brain damage, okay? And so you can see they meet the criteria for the same level severity brain damage as those kids with FAS, but they don't happen to have the growth or the facial features that would have otherwise given them that full diagnosis. And then finally, at the moderate end of the spectrum is neurodevelopmental disorder, alcohol exposed. These individuals may or may not have the growth or the face, but what they don't have is the same level severity of growth deficiency, of brain damage. So we've been conducting clinics since 1993. I've been doing this for 32 years with a clinical team. Dr. Olson here, that's going to speak next. She's our lead psychologist, has been with the clinic for decades. We're in Washington State. To get into our clinic, all you need is a confirmed prenatal alcohol exposure at any level. Single glass of wine, you're in. Drinking daily, you're in. I'm not saying a single glass of wine would have a measurable effect, but as you well know, I never know if that's anywhere close to an accurate presentation of it. So when we bring individuals in, this chart is going to show you that among the first 3,300 individuals that we diagnosed with prenatal alcohol exposure over the last 32 years, here's the proportion that end up walking out with these different diagnoses. 6% end up with FAS, 33% end up with static encephalopathy, and 53% end up with the neurodevelopmental disorder. The reason why FAS has such a low prevalence is because by definition, we require them to have the full facial features of FAS. It turns out during pregnancy that the window of opportunity to cause those facial features is not all 9 months of exposure, but it could be as narrow as just a matter of days in like day 19, 20, 21 in pregnancy when the face is being formed. Even a woman who is using alcohol constantly might miss those few days. The child will not have the facial features, but they will still have the brain damage. When we present the diagnosis to the family at the end of the evaluation, we use this single-page grid because it is an easy way, I think, for families to understand where their child is under the spectrum. So we'll just simply share with them that your child has severe growth deficiency, so they'll rank 4. They have all 3 of the facial features, a rank 4. They have severe dysfunction based on how many areas of brain dysfunction that they're presenting with. That gets a rank 3. They have an exposure that's quite high that's reported to us. It gets a rank 4. I also want to mention here now that in a prenatal alcohol exposure clinic like we do, everybody is exposed to alcohol, but it's never just alcohol. These kids come in with also a number of other prenatal and postnatal risk factors that cannot be ignored. In fact, the problems that you might see, the challenges that that child might be experiencing, you can't blame it all on alcohol and ignore all the other reasons they could also be contributing to the growth and developmental changes. So in our code, it's actually more like a 6-digit code. We actually code out what are the other prenatal risks. Prenatal risks being everything from family genetics, what have you inherited, poor prenatal care, pregnancy complications, exposures to other illicit drugs, tobacco use, I could go on and on and on. Oh, and by the way, there was also alcohol. So it's all adding up. It's not just one or the other. So, and as far as the postnatal risks, in our clinic, just by chance, about 85% of the patients coming in are kids that are in foster placement, out-of-home placement. By virtue of that, it's a higher risk group of kids. And so the postnatal risks that we often see are, there's a lot of trauma that goes on. These kids maybe have had multiple home placements, physical sexual abuse. None of these things bode well for normal development and normal growth. When we show them this grid, we'll say, okay, the 4-digit code is 4434. That's one of many codes that qualifies for FAS, fetal alcohol syndrome. So they get a real graphic kind of sense. They will also go home with a comprehensive medical summary report with all the test scores and all the data. This is just a nice one-page graphic that helps them. We've trained thousands of clinicians over the decades. And with this 4-digit code, for those of you that are research scientists like me, you like as much data as you can possibly collect. So in the diagnostic guide, there's a 12-page diagnostic form that'll allow you to record every imaginable thing about this child. Many of you, though, as clinicians, don't have time to do that. So I've created a 1-page diagnostic form. Again, you can pull this for free off our website. It covers all the bases so that it's just the minimum amount of data you need to collect to justify the 4-digit code that you've assigned. And again, the software that I'll demonstrate today is all of these things are free. So I'm going to go slightly into the weeds here with what's the neurodevelopmental profiles, and then Dr. Olson is going to finish this up. So we've seen thousands of individuals to date, and I was curious, what's the pattern of cognitive behavioral problem that they present with, and how severe is it, how prevalent is it? So the red bars here are for 102 individuals who got a diagnosis of full FAS. And what I'm sharing with you, those red bars, are what proportion of that patient population with FAS presented with severe motor problems, severe cognition impairment, severe language impairment, severe being 2 or more standard deviations below the norm. So if you look at the group, the red bars with FAS, I've put them in the order of least impacted to most impacted. So the lowest impact, only 41% had severe motor problems, 50% had severe cognition, 73% had severe language, and you can see it's moving up. So the least impacted was motor, most impacted executive function. But when I say motor is least impacted, 41% of the children had severe motor problems. So yeah, relative to executive function, it might seem less, but it's still a major impact. Then I was curious if I looked at the group with static encephalopathy, those next under the umbrella, do they have the same pattern of impairment, only just maybe a little bit less? And that's exactly what we see. We see this stair step up going from 40, 57, 70, 73, just like we did with FAS. And interestingly, with the folks with the more moderate dysfunction, yes, they have fewer of them are impacted, but it's the same kind of pattern. I am not in any way saying that this is the profile of FASD. I'm just sharing with you more. Look at the size of those bars, okay? The next way of looking at it is individuals in clinic rarely walk in with just one area impaired severely. They'll often have 2, 3, 4, up to 9. So these black bars are showing you that of the first 1,000 children that came into clinic over 8 years of age, 20% of them walked out of clinic with one area severely impaired, 21% with 2 areas impaired, 16% with 3 areas. See what I'm getting at? By the time you add all that up, 92% of the families coming through with their children, 92% of those children presented with 1 or more areas severely impaired. So is intervention needed? Absolutely. This is a population that really needs intervention. What kind of interventions are typically needed? And so our occupational therapist in the clinic, Dr. Tracy Girokowic, she did a study a while back. Again, this is published, looking at 120 children that had come through our clinic across the span of diagnoses. And just to see if we look back on our intervention recommendations, what proportion of them did we provide some level of educational intervention, accommodations in schools, special programs, things like that. And you can see that's the biggest one, where 91% of these kiddos coming into clinic needed educational help above and beyond what they might have already been receiving. 82% of them, of our recommendations, were for medication management, medical issues. So again, you'll see from these bar charts that these individuals not only present with a fair bit of impairment, but also need a fair bit of intervention. So then $1 million question is, does the interventions work? And I think the best people to answer that question are the caregivers themselves, okay? We do a patient satisfaction survey of all children coming into clinic and ask the parents a variety of questions. So here's the results of those in the first 2,600 patients seen. We ask them, we hope you enjoyed your experience at our clinic. Would you recommend clinic to other families in similar needs? 100% said yes. 92% of them shared with us that they received information that they were unable to get elsewhere. And that counts for the big city of Seattle with every imaginable service available. But despite that, coming to our clinic made a difference for that family. 86% of them found the 4-digit code easy to understand. And I think most impressive to me is when we do send them out, we send them out with a list of recommendations of what to do next. First question is, could they find it and could they access it? And if they could access it, did it help? And so 90% reported that they were somewhat to very successful at finding the recommendations we made referrals for. And then interestingly, 96% reported that these services met some to all of their needs. In other words, the intervention services we already have established in Washington State for individual kids with disabilities and challenges, those are the services for the most part that we're recommending them go out to. Maybe Dr. Olson will share with you too that there's some very FASD-oriented interventions as well. And Jen Wisdahl, that's going to be speaking with you, will talk about it from the family advocacy perspective. Okay, $1 million question. This is a quiz question. Is there a safe level of alcohol consumption during pregnancy? It's still a debate 50 years down the road. But my answer is no. There's no level of drinking that's safe, and I underline for all fetuses, okay? It's true that while the lower the alcohol exposure, certainly the lower the risk. I don't argue with that. But risk is not just based on timing, frequency, and duration of exposure, like we've often treated it. How do I know? It's from our twin study. Our twin study confirmed that fetal genetics plays a role in how vulnerable or even resistant a fetus is to the adverse effects of prenatal alcohol exposure. And I don't mean something like a gene deletion or a gene abnormality. I'm talking about we all have different genetics, okay, what we're born with. And somehow some of us are more susceptible to the damages of prenatal alcohol exposure than the others. So one way to look at that we look back in our data is to look at twins. Twins are going to be the only fetuses where every single day of exposure is identical for the two of them, okay? And you'd expect if you had identical exposures, you should have identical challenges and experiences, correct? So with identical twins that share 100% of their genome, just with identical alcohol exposures, coming to our clinic, they both received identical FASD diagnoses. If one had FAS, so did the other. If one didn't have FAS, neither did the other. They were 100% identical. But here's where it becomes very interesting. Non-identical twins only share half their genome, okay? They're not genetically identical, but they were exposed to absolutely identical exposures. So, but it turns out that 50% of the time, those two twins with identical exposures had different FASD diagnostic classifications. On occasion, one twin's born with full FAS and the other one looks untouched. Again, there's kind of maybe the next thing we really need to figure out in the field of FASD is what is it about our genetics that some individuals are less prone to it. I've also shared with you that it's never just alcohol. There are many known and unknown risk factors in addition to the alcohol. And again, for the sake of the birth moms, I've never met a birth mom that drank for the purpose of damaging her child. Alcoholism is a disease. She often needs as much help as her children coming into our clinic. So it's really important to be accurate in how you name these things. So in the first 2,550 patients coming into our clinic with prenatal alcohol exposure, of course, 100% had prenatal alcohol exposure. But look at these other adverse effects in addition to alcohol. No prenatal care, 31%. Maternal learning disabilities that they could be inheriting, 36%. 93% of others were exposed to other adverse exposures. Prenatal tobacco, 62%. Other illicit drugs during pregnancy, 66%. Foster care, 85%. Physical, sexual abuse, 35%, 25%. These numbers are many-fold higher than the general population, but it's important. These risks don't go away just because there's also alcohol, okay? They're all just piling on and contributing. So then I did a study recently to go, is there any way we can start to figure out of all those risk factors, including alcohol, which is the riskiest, which does the most damage? And again, what study results showed that it was prenatal alcohol exposure that above and beyond all these other risk factors was the dominant risk factor, explaining over half of the challenges these individuals had. The other risk factors together explain kind of the other half, but the prenatal alcohol exposure rose above all of them in terms of being the biggest culprit. Another interesting question to ask, what would the diagnostic distribution, FAS, static encephalopathy, what would that distribution look like if alcohol was the only risk factor? We will never see that in a clinic. In 32 years of clinic, I have never seen a fetus come in where the only risk factor was alcohol. But our primate model serves as a gold standard for assessing the teratogenic impact. This was a model that I was involved in the 1980s. The exact quantity, frequency, and timing of exposure was documented in that study, and even blood alcohol levels obtained. The only risk factor was alcohol. Physical and functional outcomes were assessed using the same standardized tests that we use in humans, we used on monkeys. The results are the following, and pretty striking. Green is the primate model, blue is our 32 years of clinic. There's no difference between the two. So again, it's kind of supporting that alcohol in the clinic is the predominant risk factor driving a lot of the outcomes. I am not saying all those other risk factors aren't just that risk factors, but the predominant risk factor is alcohol. Here's what the face of FAS looks like. This is a girl with the most severe presentation, and all I could say is she's severely cute. It's why the face was often missed. It's adorable as a little kid. And as an adult, I'll show you an adult with the face, it's like, oh yeah, they have it, but you wouldn't really notice it. The diagnosis, the facial features of FAS, 3 of them. Individuals have small eyes. The distance from the inner to the outer corner of the eye is small. We measure that, look it up on an eye growth chart. The groove between your nose and upper lip, don't worry if you don't have one, is missing. You can make it go away with a smile, but it's missing without a smile. And the red part of your upper lip is thin. How smooth? How thin? We've got to come up with a language, so we're all doing the same thing. So I created these lip philtrum guides. A rank 4 and 5 on the lip philtrum guides are the lip infiltrum of FAS. So this little girl has what we call a rank 4 presentation of the face. And that face, 2 things are true. If you have that face, it confirms you were exposed to alcohol. The face is the only piece of this diagnosis that is specific to caused only by alcohol. A million things cause growth deficiency. A million things cause brain damage, but only alcohol causes the face. So we can capitalize on that. Here's what the face looks like across different races. Again, young and old, all these different races. This young man up here, the 2 pictures, that's his baby picture. Okay, and you can see he still has a thin upper lip, a smooth philtrum. Probably couldn't tell from looking at him, and he has small eyes, but he does. So the face does not necessarily go away with time. That's an old myth from 50 years ago. You got to let go of that one. The face just stays the same as far as the fetal alcohol syndrome aspect. When we measure the face of FAS in clinic, we now use a piece of software I wrote years ago that allows us from just a regular digital photo to be able to measure it more accurately than a doctor trying to hold a ruler up to a 1-year-old's eyes. So I'm going to demonstrate this software here in a minute. And maybe with the help of upstairs, do you want to go ahead and get that? So I'll narrate this. I've just opened up the software on my desktop. I'm about to. And when I open it opens up at a big gray screen. It's waiting for me to pull in some photos. So it's going to pull in John Doe. He's a real patient. He does not have FAS, okay? But he has great photos. Here's a perfect photo. On your left are the photos and on the right are the data sheets. So it's now waiting for me to start measuring them. And here's the 3/4 view that we look at, mostly so you can get a better view of that philtrum. And then we also take a lateral just to be complete. So now I'm going to blow up this picture so that we can start measuring his eyes and lips. And I put a sticker on his forehead. That's my ruler in the picture. So then I'm going to go to the eye tab and tell him what eye chart to use and also what size sticker did I put on his forehead. And next thing I'm going to do is measure that sticker in little pixels of light called pixels so that I know the conversion factor. And now I'm measuring his eyes. I'm going click, 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 and now the software just measured both eyes, looked it up on a chart, and is going to tell me that if you look at the bottom, his mean palpebral visual length was 28 millimeters, and that is 0.97 or almost 1 standard deviation above the norm. We're looking for eyes that are -2. He's +1. His eyes are fine. He does not have the eye size of somebody with FAS. But now we've got to measure the philtrum in the lip. And for measuring the philtrum, we just use, again, the lip philtrum guides, a pictorial map. But in order to measure the lips more accurately, we're going to actually take the mouse and outline his lips. And as soon as I do that, the computer is going to automatically, I'm just checking my time here, is going to automatically tell you which rank 1, 2, 3, 4, or 5 that lip is on the lip philtrum guide. Again, I'm trying to take the human error out of this and just get it more distinct. There's also a tab on there for anomalies in the event he presents with any other anomalies or syndromes. There's a quality tab that allows you to say these are really good photos or they're not so good, maybe you shouldn't trust the measurements. And then it just measured his eyes and is sharing with us according to the 4-digit code. He has none of the facial features, okay? He has a perfectly normal facial features, and you just press a button and all that data ends up in one page that you can submit to the medical record. That was real time, so it took us about 2.5 minutes to accurately measure the software with the software. Here's a little girl, we'll do it one more time quickly. This little girl does have the facial features of FAS. And in this case, when we measure her eyes, we're going to need to pick a different set of normal charts. We're going to pick the normal charts for eye size for African Americans. They have bigger eyes than Caucasians. So we're doing that, and we're going to now measure her eyes by first clicking on the ruler to get that size into the computer, and now we're going to measure her eyes by clicking the inner and outer corners of both eyes. And for you clinicians, you can probably see how much easier this is than trying to hold a ruler up to a moving 3-year-old. And her eyes are 3 standard deviations below the norm for African Americans. She has very small eyes. You can also see the need to measure them, not just look at them and go, you look fine. Her eyes look big because her whole head is small, okay? So we're going to measure her lips, and I think you can see already she has no philtrum groove. And we're going to outline her upper lip, and she has a very thin upper lip on an African American lip philtrum guide. These folks have thicker lips than most Caucasians. We also use that guide for Aboriginal Australians, some East Asians, whatever populations tend to indigenously have thicker lips. The medical doctor is supposed to use the thicker lipped guide. Everybody else, the thinner lipped guide. So again, we hit the outcome button, it automatically reports that she has all 3 of the facial features of FAS, and it's going to print out a report for you. So since we have this user-friendly software and the face of FAS is so specific to FAS and prenatal alcohol exposure, I and the director of a foster care program in Seattle for 10 years did nothing more than take a photograph of every kid coming into foster care. Period. No record view, that costs money. Just take a picture, send it to me, I analyze it. If they had the rank 4 face, they screen positive for FAS, and we bring that foster family in with the child into clinic and see if they had the face, do they have the growth, do they have the alcohol exposure, do they have a diagnosis of FAS? The results were we had a 98% participation rate, huge, because it's foster care and the state kind of mandated this. It turned out that 95% of the time when we found the full rank 4 face, those kids walked out with a diagnosis of full FAS. It also allowed us to count what proportion of foster care has FAS. And we found that in Seattle, Washington, foster care, over 10 years, 1 out of every 100 children had full-blown FAS. That's just FAS, tip of the iceberg. Multiply that times 10 or 15, and that's how many had FASD. These are the little kiddos. These are actual pictures with parents' permission to share with you that we took. But the ones that are highlighting here, here's the ones that had the full face of FAS and were identified, diagnosed, and then provided special interventions. Can FASD be prevented? That's the goal, everybody. Oftentimes we don't know if we're preventing it because we don't have the data, but there was a moment in time back in 1993 for 5 years, between 1993 and 1998, I, as an epidemiologist, had the very data I needed. And this was back when we were first opening up clinic, big time public health push, all kinds of prevention efforts with the Parent-Child Assistance Program. And what we found is that the prevalence of drinking during pregnancy, we have a surveillance program. We actually ask moms that are pregnant each year, how many of them are drinking. It's the CDC's PRAMS program. So we had data from those 3 years, and it dropped significantly from 15% reporting they drank all the way down to 4%. That was astounding. In the very same years, I remember that foster care population we did the pictures on? Well, I could take those kiddos and their results and group them based on what year they were born. The foster kids in that study, born in 93, born in 94, born in 95. And what's the prevalence of FAS in those birth cohorts? And you can see it went down the very same years from 7% down to 2%. The moms that are reporting the drinking, they're not these guys' moms, okay? This is public health, use of public health data. As goes moms drinking, went the same diagnostic outcomes in these kids. And even more compelling, the higher the exposure that moms are reporting reducing from, the greater the decrease in the prevalence of FAS. So I didn't discover this 5-year pattern until about 10 years after all this. So in other words, I would have never guessed we were actually being successful at preventing it because we never had any data and I had no way of looking. But when we did look retroactive, it's like, oh, it was just amazing to see. As was shared with you, we've trained over 150 diagnostic teams, thousands of clinicians over 59 countries. These bubble charts are sharing that with you, where the analysis software is being distributed. And also I didn't mention that not only are our diagnostic tools all free for everybody, so are our training programs. And if you want to learn how to use the 4-digit code, we've got a free online course that I put together. You're welcome to take that. Anybody, everybody, it's free. Call me and I'll have you signed up tomorrow. And it's self-paced. You're on your own. Quizzes, you can self-grade, that sort of thing. Here's how you get access to those different tools. And again, or just email me, astley@uw.edu, and I'm happy to hook those up with you. These are our publications on our website, fasdpn.org, are all of our publications. These are the key ones that I introduced to you today. They're real page turners. And here's our website. So thank you very much. Perhaps there's time for some questions.
Muchas gracias, doctora. Tenemos espacio para un par de preguntas. Si alguien quisiera hacerla, ahora es el momento. O las personas que están siguiéndonos en línea también pueden hacer alguna pregunta. ¿Alguien tiene alguna curiosidad, algo sobre los programas gratuitos que ofrecen o sobre los temas que se abordaron? Ah, por allá atrás tenemos a una persona interesada.
Good morning, and thank you for your acknowledgement and your participation in this in este Congreso. And I have a question for you. We can use the software to identify alcohol syndrome. And do you know if there are other pathologies with this characteristic lip philtrum? Because we may get confused at the moment of diagnostic. And the question is, what kind of tests there are for?
Okay, so in terms of who can use the software, it's medical software. It's intended for use by clinicians. You don't have to be a medical doctor. You can be anybody in a clinical arena in the medical professional, whether you're a speech language pathologist, an occupational therapist, any of those folks. It's not intended to be distributed to mom and dad, okay? So just to be clear, but essentially it doesn't require a medical doctor to measure the face. I am not a medical doctor. I am not licensed to use any of the tools I do, but I am the person who takes all the photographs and measures the photo, kind of like a technician. But the doctor ultimately is the one who has to decide, is that or isn't that the face? Now you asked a question about lip filtrums and in adults, maybe?
With lip filtrum as other pathology with similar lip
Other-
filtrum
Yeah, so
that we can confuse with this kind of
absolutely.
problem.
So that's why all three features must be present. Thin upper lips will be seen in a variety of either different genetic syndromes or smooth filtrums or small eyes, but you have to have all three at the same time for it to be specific to the alcohol exposure. So thanks for asking that question. I think you had one more question.
No, it's all for the moment. Thank you.
Okay, thank you. Yeah.
Muchas gracias por su presentación y la información. Gracias por la presentación y la información. Con su experiencia en México no tenemos muchos datos de estadísticas sobre el síndrome alcohólico fetal. Si usted tuviera que recomendarle al gobierno cómo iniciar a generar esta información, ¿qué es lo que nos recomendaría?
Hire an epidemiologist. That's what I am. And I'm sure they're somewhere in here, Mexico. Yeah, so in our state, it was our state legislature that opened up our clinic and has funded us for 32 years. And part of that funding was predicated on me being there, collecting the data, using the data to create all the diagnostic tools and collect all the stats from them. So you could follow the Washington state model and do that.
¿Más de parte de alguien de nuestro público? Por acá tenemos una pregunta. Muchas gracias.
Hi, thank you so much. The clinic does work in terms of prevention, campaigns, or...
Sorry, go ahead and say that again.
Oh, okay.
You were speaking in English, so I couldn't hear two languages.
Sorry. Does the clinic works towards prevention? I mean, campaigns or some other kind of...
Yes, so when our clinic was first opened in 1993, we were opened with our state legislature with a sister program called Parent-Child Assistance Program. We worked with kids to diagnose them and provide them with help. But as you can imagine, how you can't prevent it. They're already walking in with the damage. But we would also then, by virtue of that, learn who their birth mothers are. Oftentimes, their birth mothers were still fertile, still going to have more children, and we would refer them to the Parent-Child Assistance Program that helped them with their alcohol use and how to either improve family planning or reduce their alcohol use during subsequent pregnancies. So that's how we ended up being able to see that striking, decrease in the prevalence of FAS. I'd say the decrease in prevalence was fully due to the Parent-Child Assistance Program. That was a sister program with ours. It still exists. They too have trained folks around the world on how to use the Parent-Child Assistance Program. They should be your next phone call.
Muchas gracias, doctora.
Thank you.
Debido a que nuestra ponente tiene un vuelo que tomar, ahorita vamos a dejar aquí. Si alguien tiene otra pregunta, por favor, háganosla llegar y con gusto veremos la manera de resolverla. Mientras tanto, nada más felicitarla, agradecerle que haya venido con nosotros y reconocerle por esta extraordinaria ponencia. Perfecto. Muchísimas gracias, doctora. Buen viaje.